Good morning. Today I'd like to talk about a multi-stage AI analysis system to support prostate cancer diagnostic imaging across multiple centers and scanners. Some disclosures related to this work. Many of us are either employees or co-founders of Lucida Medical Limited, the company that develops the AI software described here. The AI software described here is not yet currently available as a commercial medical device. We are in the process of getting regulatory approvals. And if you want more information on that, then please contact myself. So just a bit of background about prostate cancer. It is the most common cancer in many countries, with 1.4 million men diagnosed with prostate cancer every year, and that leads to around 375,000 fatalities. Compared to earlier methods, it's been shown that a pre-biopsy MRI improves the detection of clinically significant prostate cancer. That's defined as a Gleason grade of greater than or equal to 3+4. Within that, there are continuing issues with overdiagnosis and underdiagnosis, overdiagnosis leading to unnecessary biopsies, and overall variations in achieved quality and consistency mean that we're always looking for ways to improve things, and that has stimulated interest in artificial intelligence to supplement the interpretation of prostate. So the background to our work here is that we are aiming to develop and validate an AI system for prostate MRI based on real-world diagnostic imaging. So we're using multi-center data. We have data here from a retrospective study, Pair 1, that we are running. And we have results also, we have data also from the Prostate X dataset. And this means we have a combination of 1.5 Tesla and 3 Tesla data from 2 centers. So we have a system that utilizes our proprietary multi-stage AI architecture to find the prostate gland, segment it, and make cancer risk estimates of suspicious regions, lesions within the prostate gland. Our dataset consisted of 204 patients from the Prostate X dataset and 87 cases from the first of our sites in the Pair 1 study. They all used multiparametric MRI. So we divided that data set into 3 groups in a classic way. 177 cases used for training, 55 cases we used to validate that training, and then we had a held out set of 59 cases to test the final models. On evaluation, the performance was evaluated with data used both for the test and validation. We did not use any of the model training data. Results solely from the held out test data were similar to those reported here from the 2 test and validation datasets. So if we look at the results, this is the ROC curve at the patient level for detecting clinically significant prostate cancer versus the biopsy ground truth. So we see here that, actually, I'll show you on the next slide, the area under the curve here is around 0.86. You can see that for a sensitivity of around 90%, we'd have a false positive rate of about 35%, and we could obviously operate in different parts of this curve, giving us the power to for high sensitivity or for a very low false positive rate, whichever is the requirement of a particular center. Now, how does this compare with other studies, and particularly with radiologists? We see here, this is the current study where we have a sensitivity of 93%. And a specificity of 66%. This compares very well with studies with radiologists, historical studies. It has come down a little bit from our previous research, which was solely based on the Prostate X dataset. And this was to be expected because now we've got a larger variation in the type of input data. We have different studies, different acquisition protocols, and more importantly, different scanners. So we have multiple manufacturers and the 1.5 and 3 Tesla range of imaging. Our area under the curve has come down a little bit, but it's still, I think it's still good. It's still demonstrating that we can add value and detect cancer in a reliable way. At the lesion level, compared with what we had before, again, we have come down just a little bit from 94% sensitivity to 92%. The area under the curve has come from 0.9 to 0.83, but we're still detecting cancer at a high rate. Again, just to emphasize, this is all against biopsy ground truth. So we're not comparing with radiologists, we're comparing with the outcome of biopsy. So already into conclusions. So the more diverse data does appear to impact performance. Compared to a single center 3 Tesla data study, performance of the AI system has moderately reduced when trained and evaluated on both 1.5 and 3 Tesla multi-center data, with per patient specificity reduced from 78% to 66% at a sensitivity of 93%. So we've still got good performance. This performance remains comparable with central reporting by expert radiologists reported in major studies, suggesting the software could be used to support reporting and assessment of pre-biopsy MRI for prostate cancer, independent of field strength and center settings. This is early days. We will extend this work. We're going to add extra sites. In fact, we will be heading towards 7, possibly 8 sites for this work. And we hope, therefore, to increase the diversity of the data set and show that we can generalize even further than we've already done. And we are seeking CE and FDA certification of the software, partially based upon the results of these studies. So I think this research has demonstrated it's possible to develop a more generalized artificial intelligence-based software for prostate MRI that can generalize to multi-center, multi-field strength data, and that can have a big impact on the diagnosis and staging of prostate cancer in men. Thank you very much.